Now we have our chief instructor, Dr. Natasha ma'am, on stage. She will talk to us on the topic, present a case on the topic VKH, or is the diagnosis more ominous? Over to madam.
Thank you. So this is a 32-year-old lady. She has been on investigation for interstitial lung disease. She's been on MMF and systemic steroid. They are also suspecting systemic Sjogren's. The right eye was 6-6 with some serous retinal detachments away from the fovea. The left eye also had one serous detachment away from the fovea. And you can understand the macula is not involved, the disc is not elevated. There was nothing to suggest anything other than CSR and steroid-induced CSR. The autofluorescence of the right eye showed some RP changes in that area of the SND and nasally also. Left eye also showed RP changes, patchy RP change. And the OCT through the lesion showed a proper sensory neural detachment. Fovea was normal in both eyes. The first clue that came that this may not be CSR is when we did a fluorescein angiogram and there was no CSR. Why did we do a fluorescein angiogram? Because this patient had systemic disease and also because between 1 week these patches were increasing. So our plan was that if it is a multifocal CSR due to steroid, we can do a laser for it. That is why we did a fluorescein angiogram. And it was bilateral. And it didn't show a typical CSR leak anywhere. It was just a few RP changes, window defects, and tiny pinpoint kind of leakages at the area of the fluid. The ICG also showed a few areas of hypofluorescence and nothing else. So she was advised to taper and stop steroids. We were still going ahead with the diagnosis of a steroid-induced CSR. And then a month later, she came back with vision 618 in the right eye, 6.9. Fluid at the fovea has increased. Extensive RP changes are still there. And this is the picture. So you're having some kind of intraretinal fluid also, sensory neural detachment also, like the fluid has been there for some time kind of picture. And nothing gave us any clue. Repeat FFA was done, didn't give us any clue. These pinpoint dots like things, we thought, is it a VKH we are looking at? Because there was mild disc leak in one eye, other eye there was no disc leak. And these pinpoint leakages seemed, at that time we had no other diagnosis to go with, so we went with VKH. And because of these tiny dots that you're seeing in the area. But you can see strikingly, keep this in your mind, now also you can see strikingly what you're seeing is retinal pigment epithelial damage that looks much more than what we get in a VKH. And we looked at the choroidal thickening, not much, 2.4, 2.6, slight choroidal thickening. But then ESR was 101. Patient has systemic inflammatory disease. So we decided to go ahead thinking that it is inflammatory. So we increased the MMF to 1 gram TID. IVMP was given because her vision was dropping, and then tab Visolon. 1 month later, her right eye vision has dropped further to 636. Left eye has improved to 6.6. And this is the picture. Extensive RP defects on the AF, and the fluid itself seems to have reduced a bit. But there are some hard exudates, but OCT is showing massive sensory neural detachment still persisting, and it's starting to look chronic. You can see the lamellations, outer retinal tubulations that we see in chronic fluid. 2 weeks later, right eye is worsening further. The RP changes are worsening further. Fluid is increasing. She's on top immunosuppression. There is nothing else we can add anymore. And this typical picture is there on the AF. And the AF picture is has always been out of proportion to the findings in the fundus in both eyes. And the fluid is relentlessly increasing. And we are at a loss what to do. This is the fluid weekly. We are sitting very high-fi patient, known to a lot of people. So we are getting calls every day about what is this patient's diagnosis. We have no clue, but we can't tell them that. So this is going on, and we are hoping that it will repeat. Then we discussed with pulmonology. We repeated the HRCT, and they are telling us that the systemic interstitial lung disease has come down, and whatever systemic pathology has come down. And then looking at these AF, so leopard spots, what we call that AF picture, and they can be in VKH like inflammation, it can be in uveal effusion syndrome. So we sent this picture to Vaishali ma'am in PGI Chandigarh and took an opinion from her. She said it looks like uveal effusion syndrome, and if you remember Anjana's case, definitely those RP changes are looking like uveal effusion syndrome. So the next step is to do a scleral window tapping of the fluid and drain the SRF. And both of us have been, like, I was working with Dr. Gopal at that time, and both of us have been fighting about this case from the beginning. He saying it is inflammatory and me saying that it doesn't look like VKH. So because of that, he was reluctant to go in for a scleral window surgery. I was reluctant to let him do a scleral window surgery. So I said, no, we need to look at it a little bit more. So then we asked them to take a opinion from, they gave them the option of a second opinion. We said that the next step is surgery, but why don't you take a second opinion from somewhere? They were ready to go to Aravind, so they took an appointment at Aravind, Madurai, and they were waiting for going there. 1 week there was a delay between our telling them and them going to Aravind. In the meantime, the patient developed a severe backache. Patient cannot stand, and she went to the rheumatologist, and they did an MRI spine. And this MRI spine showed aggressive myeloproliferative disorder. That is what they told us at that time. But ultrasound abdomen showed us bilateral ovarian deposits. Bone marrow biopsy showed metastasis with probable primary in the breast. Breast ultrasound showed invasive lobular neoplasms with metastasis. So a retrospective diagnosis was B-dump, bilateral diffuse uveal melanocytic proliferation as a paraneoplastic syndrome of the systemic malignancy this 32-year-old lady was having. And there is no way we would think of malignancy, because she was young and she was fit, and except for her interstitial lung disease, she was really quite fine, mother of 2 children and running around. Then the patient underwent chemotherapy. Of course, scleral window was never done, second opinion was never sought, and she underwent her treatment, and slowly the fluid came down, and she's maintaining at 612, 6/9 parts vision. So this was the last AF picture that we have, with the RP completely destroyed by the B-dump. And the OCT was slowly resolving. So we were fooled because of the young age, inflammatory nature of the lung lesion, and a high ESR of and CRP, and pinpoint hyperfluorescence that we mistook for VKH, the mild choroidal thickening, the SNDs, and all that. So what is B-dump? It was described by Makimer in 1970, and 5 cardinal findings: reddish-brown lesions at the level of the RPE, hyperfluorescent spots on FFA, slightly elevated pigmented or non-pigmented. They are basically small tumors, and diffuse thickening of the uveal tract, exudative retinal detachment, and rapid development of cataract is said, but our patient did not develop cataract. They have only been 31 at that time when I did the research about this case, and primary is usually from the lung, ovary, leukemia, lymphoma. It is not common from the breast. Usual age group is above 50, and disc leakage is uncommon. So leopard skin appearance. So that is the take home point from this whole exercise, that leopard skin appearance is not there in VKH. So if you see exudative retinal detachment with RPE changes that are out of proportion to the serous detachments that you are seeing, always think of one is your uveal effusion syndrome, all the 3 types, and second is paraneoplastic syndrome, irrespective of the age group of the patient. And there were no signs of inflammation in this patient. Even like when we were treating with immunosuppression, there were no posterior vitreous cells. The disc leak was very cannot be commented as a proper disc leak. Bilaterality, definitely disc was not leaking. So that should be kept in mind. And I would also take this opportunity to invite all of you to Ignite on January 10th and 11th in Kochi, a dedicated uveitis and inflammation. This time the theme is uveitis for the general ophthalmologist. So please do attend and make it a success.